Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. In this third episode of Antipsychotics, we explored the transition from the rigid dopamine-blocking power of the first generation to the more nuanced dual-action approach of the second-generation antipsychotics or SGAs. These medications, often called the atypicals, represent a massive shift in psychiatric treatment that occurred in the 1990s. While the first generation focused almost exclusively on the dopamine 2 receptor, the SGAs introduced serotonin modulation into the mix. This change was designed to treat the full spectrum of symptoms, not just the hallucinations and delusions, but also social withdrawal and lack of motivation. Unlike their predecessors, these medications do not just block dopamine. They also interact with various serotonin receptors, particularly serotonin 2A receptor. This dual action is what makes them atypical. By modulating serotonin, these drugs are thought to allow for a more natural flow of dopamine in the motor centers of the brain, which is why they are much less likely to cause the abnormal movements seen with the first generation. However, moving away from movement-related side effects introduced a different set of challenges. Because many second-generation drugs also impact histamine and other serotonin receptors, they can significantly affect the body's metabolism. Patients and clinicians must carefully monitor for weight gain, increased cholesterol, and changes in blood sugar, as some of these medications carry a high risk for metabolic syndrome. Despite these trade-offs, atypicals expand the reach of antipsychotics, with many being approved not just for psychosis, but also as add-on treatments for depression and stabilization of mood in bipolar disorder. The choice of an SGA medication is often a highly personalized decision based on a patient's specific needs and their sensitivity to metabolic changes. For example, some drugs in this class are known for being very weight neutral, while others are highly sedating, which might be beneficial for someone struggling with severe insomnia, but a drawback for someone needing to stay alert at work. Among the most commonly prescribed is risperidone, which is used for schizophrenia, bipolar 1, and irritability in autism. It is typically dosed between 2 and 8 milligrams daily and is noted for its high potency, though it carries a higher risk for elevating prolactin levels. Quetiapine is a versatile medication used for schizophrenia and bipolar disorder, as well as an add-on for depression. It is highly sedating, with doses ranging from 150 to 800 milligrams, and is often utilized at lower doses specifically to help with sleep. One of the most effective medications in this class is olanzapine, approved for schizophrenia, bipolar 1, and treatment-resistant depression. While it is powerful at doses of 5 to 20 milligrams, it is also known for having the highest risk for weight gain and metabolic changes. To address the metabolic burden of olanzapine, the fixed-dose combination Lybalvi, consisting of olanzapine and samidorphan, was developed to preserve clinical efficacy while mitigating weight gain. While olanzapine is highly effective, its potent histamine 1 and serotonin 2C antagonism typically drives significant adiposity and insulin resistance. The addition of samidorphan, a mu-opioid receptor antagonist, modulates reward-based feeding behaviors to counteract these metabolic shifts. Clinically, the primary caveat for Lybalvi is its absolute contraindication in patients using opioid analgesics. Because samidorphan is a high-affinity opioid antagonist, its administration can precipitate acute, severe withdrawal. Therefore, patients must be opioid-free for 7 to 14 days prior to initiation. For those seeking a more weight-neutral option, ziprasidone is an alternative for schizophrenia and acute bipolar 1, typically dosed between 40 and 160 milligrams. However, it must be taken with at least 500 calories of food to be properly absorbed. Paliperidone is the active metabolite of risperidone, used for schizophrenia and schizoaffective disorder at 3 to 12 milligrams, and is frequently administered as a long-acting injection. Lurazidone is a go-to treatment for bipolar depression and schizophrenia with a dose range of 20 to 120 milligrams. It must be taken with food, but is favored for its very low metabolic risk. Acenapine offers a unique delivery method. It is taken as a sublingual tablet or a patch for schizophrenia and bipolar mania at 10 to 20 milligrams. The patient must avoid eating or drinking for 10 minutes after use to ensure absorption. Finally, iloperidone is used for schizophrenia and bipolar disorder at 12 to 24 milligrams. It is particularly valued for its low risk of causing akathisia, though it requires a slow increase in dosage to prevent orthostatic hypotension. The recent FDA approval of milsaperidone in February 2026 marks a unique addition to the SGA armamentarium. Classified as a new chemical entity, milsaperidone is the active metabolite of iloperidone. Upon oral administration, it rapidly interconverts with iloperidone, providing dual active molecules that antagonize D2, serotonin 2A, and alpha-1 adrenergic receptors. Clinically, milsaperidone requires a structured titration to mitigate the risk of orthostatic hypotension and syncope caused by its potent alpha-1 adrenergic blockade. For schizophrenia, the target dose is 12 milligrams BID, achieved through a 7-day titration starting at 1 milligram BID. For bipolar mania, the titration is accelerated to 5 days to reach the same 12 milligrams BID target. Notably, if more than 3 days of dosing are missed, the titration must be restarted from day 1. Now, let's look at clozapine. While clozapine was technically the first atypical antipsychotic ever discovered, it remains the most powerful and effective tool in the psychiatric arsenal. Often referred to as the gold standard, clozapine is reserved for treatment-resistant schizophrenia, the cases where at least 2 other antipsychotics have failed to provide relief. Because of its superior efficacy and its unique side effect profile, it requires a specialized monitoring system, making it both the most challenging and the most rewarding medication to manage. Clozapine is unlike any other antipsychotic because it binds to a vast array of dopamine, serotonin, histamine, and adrenaline receptors. Clozapine's broad impact is exactly why it works when nothing else does. It is the only medication proven to significantly reduce suicidal behavior in patients with schizophrenia and schizoaffective disorder. For many individuals who have spent years cycling through different medications without success, clozapine offers a dramatic reduction in hallucinations and a return to a level of functioning. However, this high level of effectiveness comes with a unique set of safety requirements. The most serious risk associated with clozapine is a rare condition, agranulocytosis. Because of this, patients were required to participate in a strict federal monitoring program known as REMS, or the Risk Evaluation and Mitigation Strategy. These involve regular blood draws, weekly at first, then bi-weekly, and eventually monthly. Beyond the blood monitoring, clozapine has a distinct set of physical side effects that require careful management. It is highly sedating and can cause significant weight gain and metabolic changes. One of its most unique side effects is sialorrhea, or excessive salivation, which often occurs at night. It can also cause severe constipation and, in some cases, lower the seizure threshold at higher doses. This era of medicine marked the beginning of a more individualized approach to psychiatric care, where the goal shifted from merely stopping symptoms to improving the overall quality of life. Okay, that's it for today. If you found this episode useful, share it with colleagues across disciplines. Thanks for listening, and watch for the next part of the antipsychotic series, the unofficial 3rd generation. Until next time.